So welcome to Pharmacodynamics. Feels a little odd starting so late in the semester. You guys have already been here for like a month already. It's old hat to you, but you're all new to me. So I'm going to just put out of my mind what all the other professors have said about your class so far. I'm going to start fresh. I'm just kidding. I'm kidding. I said you're all amazing. Yeah, but this is going to be this will be interesting for you, I think, hopefully. So this is pharmacodynamics. Obviously, this is the intro to pharmacology. We have Pharm 1 and 2 in the subsequent semesters, and then we will have ClinPharm, who Professor Q actually helms that course. That'll be in your next summer semester. That'll be your advanced didactic. So it all kind of plays in and builds into one another. But again, this is laying the groundwork. So it's a fairly short course. It's only 1 credit hour. There's 16 hours of instruction. So again, we're not getting super in-depth on mechanisms of actions of specific drugs. We're not getting into all the kinetics of all these drugs. But you need to know the terminology, you need to know the definitions, and you need to know the concepts that we're really going to be hitting hard in Pharm 1 and Pharm 2. If you don't have a good grasp of it here, you're going to have a hard time in the next couple semesters here. Now, who's heard things about my classes before? Anything good, bad? Hard? Okay, yeah, so amazing. Thank you. The money's finally being put to work. No, yeah, so this class is not going to be indicative of the tests that you'll see in Pharm 1 and Pharm 2. This is going to be a little bit simpler in terms of the level of questions you're going to be getting. So we do have one test that's going to be at the end here. It's 50 question multiple choice, kind of similar to what you've already done. But again, it's not going to get to the same level that we're going to be seeing in Pharm 1 and Pharm 2 because that is much more drug specific when we're talking about treating hypertension, diabetes, etc. This is going to be more like what are your definitions for certain things, like looking at concepts and being able to apply those to certain scenarios. So don't get too worried about this first test. It's not that bad. I'll tell you, I've never had someone fail this test. And again, some people are like, well, I might be the first one. You won't be the first one, right? If you got into this school, you're going to be good. I have no worries about that. But to offset that a little bit, there is going to be a prescription writing assignment. It's already posted. If you look at the Canvas, it's not going to be due till the end of the course. You'll see the due date that's on there. We'll talk more about that when we get into the specifics of writing prescriptions. So don't worry about that one. You can sit on that a little bit. It doesn't take too long to actually do. It's just a matter of getting the info about it beforehand. And of course, you need a 75 or greater to pass. Let me look at the Canvas page real quick. Oh, one other thing that I do consistently, I record all of my lectures. I don't know if many of you have heard that before. I record them all. I will then post them up onto a YouTube link, which I'll put on Canvas. You don't have to subscribe to me, although it makes me feel really good. I get no money from it, but it was good because actually last year around this time, I needed 100 subscribers, so I got my own URL. And I finally got 100. Now I'm over 200. So I can barely fit my head through the door. It's so amazing. But again, I make no monetary gain from my YouTube channel, so no worries about that. Anyway, so some of the stuff on the Canvas page you're going to see here, obviously your syllabus. Again, this is kind of what I'm already talking about anyway in terms of the course details. You'll see some resources here as well. So you guys have ever heard of LexiComp? LexiComp is kind of like my go-to drug reference. That's what I use in most organizations that I've worked at, and maybe something when you're working clinically you'll run into. But it's a very good drug reference in terms of looking at dosing, looking at mechanisms, all that kind of good stuff, right? Have you heard of UpToDate? Okay. You'll get very comfortable with UpToDate. You're probably going to rely on it as a crutch in a lot of cases. That's okay. A lot of people do too, right? I remember at our hospital that the subscription for UpToDate went up like crazy in price, and there was almost a revolt in the physicians and the mid-levels when they said that we're not going to use UpToDate anymore. We're not going to pay for the subscription, and they almost all left because they use it so much. They're owned by the same company, so you can actually, if you search for a drug on UpToDate, it'll take you to the LexiComp page. So that's kind of useful and maybe handy when you're doing your prescription writing assignments and things like that. So those are good references. And then there's a pharmacodynamics sticky board. This is something else I do. How many of you are super vocal and like to speak up in the middle of class? Not many of you. I get that. I encourage it. If you have a question, just stop me, and I don't mind having a discussion. But I do this sticky board here, and you can just basically go to the external link, and basically it'll take you to this page here. And this is a good way to kind of anonymously ask questions, and so you can do it in the middle of class. I'm not going to look at it till either the break time or at the end. But you can just put up a sticky note and say, hey, what the heck are you talking about with this? This didn't make sense. Can you explain this? Whatever. And I'll go over and address those. Again, that's anonymous, so you don't have to worry about kind of outing yourself if you feel silly asking a question, although there are no silly questions. I've again, I take all questions pretty seriously. So, any questions so far? Any sticky board questions? I'm just kidding. No. But yeah, so I'll check on those usually at the break and at the end of the class there. My background, just so you guys know, I'm a pharmacist by trade. I went to the UF College of Pharmacy. I then did a 2-year fellowship in clinical toxicology and emergency medicine up at the Poison Center up in Jacksonville. So I really love drug overdoses. I love spider bites, snake bites, all that kind of stuff. I don't like it when people overdose themselves, but when they do, I love to take care of them. Like, those are my favorite kind of patients, especially the snake bites. Those are great. And how many of you are natural born Floridians? So you're somewhat familiar with the snakes around here. Those that are not, we have a lot of snakes, FYI. Eastern coral snakes and rattlesnakes and all kinds of good stuff. I love to deal with those. And it's summertime. They're nice and warm. It's especially hot outside, so I'll probably get a lot of calls for those coming up here. Because I do take call for the Poison Center still. I do that about 3 times a month. But clinically, and every Monday, I'll actually be over at Nemours Children's Hospital. So that's kind of my other thing that I like to do is I like to work with pediatrics, and so I'm a staff pharmacist over there. Do that on Mondays. It's great because I can come back and tell you about all the cool stuff I see over there. So I'm like, hey, kid came in and we had to put them on ECMO because they had sepsis due to this bug, and we use these drugs on them. It's a really good way to kind of link back the stuff we're talking about into an actual patient case, and so that's what I like to do with my clinical time. So that's kind of me. I got 2 little girls. I'll probably overshare about them quite a bit when they do silly stuff that has references to drugs. It happens more often than you think. You think a household with 2 pharmacists in it would be very good about keeping your kids out of stuff in the cabinets. It still happens. Kids are notorious for that. But any other questions before I get started into the actual meat of the topic here? Okay, fantastic. So let's talk about some definitions. First off, looking at a drug, everyone's familiar with ibuprofen, correct? Everyone's at least seen it in the CVS, Walgreens, etc. Now, typically when you're talking about drug names, you'll find that it has a trade name, which is the brand name you're going to see there. So what's the brand name for ibuprofen? Anyone know? Motrin, that's another one. Advil, those are the 2 most common ones, right? You'll see a lot of drugs being referred to it just in general by its brand name, but really every drug is going to have a generic name on there. So in this case, it would be ibuprofen. That is the actual chemical substance name that got approved by the FDA. FDA stands for Food and Drug Administration, right? So they kind of handle all of that. They also handle cosmetics too, which is something not a lot of people know. But anyway, so they will have the generic name and they'll have the trade name. For my purposes of my test, I will always put the generic and then the trade name in parentheses. The reason why I do that is to get you familiar with looking at both of these. Because when you go on to, say for instance, you go out to the hospital and you go in the ER and someone wants to use an NSAID IV, they'll typically say, give me some Toradol. Or I'm going to order Toradol for this patient. That's a brand name. If you didn't know that, you may want to know the generic name too. But you're going to find that most people will refer to some drugs just by their brand names. And so it's important to be able to know both of those, right? On the pants though, anyone know what they put on the pants? Just generic. So you still have to know the generic names. And in general, it is safer to know the generics because brand names can get mixed up. They can sound similar to one another, right? It's a big issue with medical errors is that things get mixed up because they look or sound similar to one another, okay? So I think it's important to know both of them. At a bare minimum, you should at least know the generic because that's what's going to be on the pants. But again, I want you to enforce that familiarity, so I will have both on my test, okay? So just FYI. Anyway, getting down into it, we have the classification for the drug itself. Usually drugs will be classified based on their mechanism of action, okay? So as an example here, you'll see that ibuprofen falls into the category of NSAIDs. NSAIDs just stands for non-steroidal anti-inflammatory drug. So based off of that name, what do you know about that drug already? Not a steroid, and it's an anti-inflammatory. You already know a lot about the drug. You haven't even been in my class yet. That's fantastic. So a lot of times we'll put it right there in the categories itself. More specifically, though, when you actually get into the mechanism, that is specifically what that drug is doing to the body to elicit its actual effects there. So in this case, to be more specific, yes, it's non-steroidal. Yes, it is anti-inflammatory, but it's a cyclooxygenase inhibitor. Anyone ever heard of the COX enzyme? There's COX-1 and COX-2. We'll talk about those at length, but this is an enzyme that it will inhibit. By inhibiting that enzyme, you decrease prostaglandin synthesis. By decreasing prostaglandin synthesis, you get less inflammation. It's great. Provides analgesia, which is what? Pain antipyretic, so it does what? reduces fever, lowers your temperature, right? So again, all through that same mechanism, that cyclooxygenase inhibition, right? So again, one of the things you'll find on my tests is that when I write a test question, so especially in Pharm 1 and Pharm 2, we'll get to those vignettes, we'll say, okay, you got this age patient, come with this disease state, what do you think is going to be the best drug for this patient, right? And you'll get 4 drug choices. And so your job is to be able to link back and say, okay, ibuprofen, I see that as an answer choice. I know ibuprofen's an NSAID. Okay, I know NSAIDs, they work by blocking cyclooxygenase. Okay, this is, yes, it's a good drug for this patient, that's the right answer, or no, it's a bad drug for this patient. I'm not going to pick that one. So it's important to make these linkages in your mind, and we'll talk more about study tips and stuff when we get into that. But I want you to start to make these associations when we get into the specific drugs themselves, okay? Anyway. Then getting into it, we'll talk about indications. So indications are typically what the drug companies have brought to the FDA to say, like, this is what we want to use this drug for. We want to use it as an anti-inflammatory, as an analgesic, and as an antipyretic. And the FDA will say, what's your evidence? They'll show them the clinical trials, and they'll say, okay, you get these indications. Okay. Now, what if I wanted to use ibuprofen for something else? Could I do that? Yeah, there's what we call off-label use, right? So a lot of drugs get used for purposes that they were not expressly designed for when they were originally made, okay? That is okay. It's okay to use things off-label, and very frequently you'll find, especially if you look up drugs like in Lexicomp or other drug references, it'll say, hey, if you're using it for this purpose, it's off-label, and we'll kind of put that in parentheses. That's good to know because you may find that off-label things may not have as good evidence for the dosing. It may be not as used as frequently for that. A lot of different things, but just to know, when it says an indication, that's what actually the FDA has approved that drug for, okay? Next up, pharmacology. What is that? It's basically the reaction of drugs in the body, talking about the interaction between drugs, what the body does to the drugs does to the body, etc. That is all pharmacology. To break that up further, you have 2 topics here. We have pharmacodynamics and pharmacokinetics. The difference between those is that dynamics is specifically what the drug is doing to the body. So in the case of ibuprofen, it's inhibiting cyclooxygenase, and that is causing anti-inflammation. It's causing the fever to break. It is causing pain to be relieved. That is the pharmacodynamics of that drug by inhibiting that prostaglandin synthesis, okay? It has to do with the concentration of drug in the body, or how much drug I'm giving, how much is getting to the tissue to have its mechanism of action, and what effects you're going to be seeing there, right? Now, is there any drug that is 100% absolutely safe, no side effects? Doesn't exist, right? Anything can be toxic, right? Anything can be a poison. Can water be a poison? 100%, right? Anyone remember the Nintendo Wii? I hope you guys have not aged me out so bad that you don't even remember having a Nintendo Wii. But there was a period of time where it was really, really hard to get a hold of, and so they were having a radio contest and stuff for people to win one. And there was a contest called Hold Your Wii for a Wii. So I had people drink a ton of water and see how long they could hold their urine for, and whoever held it the longest got a Nintendo Wii. Well, someone decided to do that, and they're participating, and what happens to all that water in the body once it gets absorbed? Well, it dilutes out everything, right? It dilutes everything out in the blood. What's the primary ion, positive ion in the blood? Sodium. Well, what happens when you dilute all that sodium? You get hyponatremia. That leads to severe issues with nerve conduction, right? You're already covering that with Professor Kaplan. All your action potentials are all screwed up, and guess what? The person had seizures and died because of hyponatremia due to water intoxication. Anything can be a poison in large enough doses. So when we're talking about these drugs, we're talking about everything in a gradation of their therapeutic effects and also their toxic effects. And oftentimes we're balancing out the risk versus the benefits to decide if they actually weigh out to where I want to use this drug or I don't want to use this drug based on a number of different factors there. Okay, so in general, pharmacodynamics is how the drug affects the body. Okay. As an example, let's use, and again, people probably think, whether fairly or unfairly characterized, me as an alcoholic. Only because I use ethanol for a lot of my examples, because I think it is something that's quite ubiquitous within society. Now, all of you are young, studious individuals. I'm sure you've never had any contact with alcohol whatsoever, correct? Fantastic, good. Let's keep it that way, guys, all right? Next 27 months is tough. You might be tempted to hit the bottle to relax a little bit, but don't do it. It's a trap. But anyway, let's look at the effect of concentration of alcohol in the body to see what its different effects are, right? To go back to illustrate the pharmacodynamics of the drug itself. So ethanol, again, that is a drug, right? A lot of your patients may be exposed to it at low doses. Say you're a drink or two in, you're at the bar, feeling pretty good. Maybe you see a person at the bar, you're like, I want to go talk to them. Normally you wouldn't, but you're like, I'm going to go talk to them, right? That's that social lubrication. sort of thing you get with that, right? So that's low dose effects, right? You can see that. When you start to get to moderate dose, say like, oh, maybe I'll wait a few more drinks before I go talk to them. 3 or 4 drinks in, now all of a sudden you're trying to walk over to them, you're a little incoordinated, maybe you're ataxic, you stumble around, you go, hey, how you doing? You're not going to sound all that too suave as you would have a few drinks ago, right? So you have slurring of your speech, right? High dose, get even higher than that. So you got rejected, and you say, let's do some shots here, okay? And then respiratory depression, syncope, etc., right? So again, it's all this gradation. It depends on how much drug was administered to what kind of effects you're going to be seeing with that. Similar to insulin. If I give you a little bit of insulin, blood sugar will drop a little bit. If I give you a lot of insulin, you get hypoglycemic, you seize, and you die, right? It's all on this spectrum here. But again, these are the effects of the drug on the body. Now, the kinetics are going to be what the body does to the drug, right? So this is the whole principle of how do we absorb drugs into the body? Once they're absorbed, where do they go to? Do they stay within the bloodstream? Do they distribute out to the tissue, the adipose tissue? Once they are distributed, how do they get metabolized? How do we break down the drugs? Do they get broken down at all, right? It can be specific for each drug. And then finally, the elimination, how do we get rid of it? Does it go out through the bile? Does it get peed out with the urine? Where does it go to, right? This is what we're trying to figure out with the kinetics here. And every drug will have kinetics that have been defined for it. And you'll find in those references, it'll say how it's metabolized, how it's distributed, how it gets absorbed, etc. And we'll have a whole lecture just on these components here. And these are really critical points to understand because, again, if you're a patient, you're dosing a patient with a drug, and all of a sudden they can't clear that drug anymore, say their kidney function goes down and they can't get rid of it, what do you think is going to happen? They get toxicities, right? They can have all kinds of issues that can happen with drugs hanging around for too long. So again, this is going to be what the body is doing to the drug. That is the pharmacokinetics. Okay. So again, ethanol being my example here. So imagine if I were to give any of you alcohol, I imagine all of you are alcohol naive, meaning you're not chronic drinkers, right? You may be able to metabolize alcohol at roughly 20 milligrams per deciliter per hour. It's roughly 1 drink per hour you'd be metabolizing it, right? Well, what if I had someone who's a chronic drinker? So I take one of your professors randomly and say, let's get Sometimes we got to cope with you guys too, right? So it's not just a one-way street. I'm kidding. But let's say I took a chronic drinker, right? And so I was able to measure how much they were metabolizing. Well, due to the fact that they're chronically being exposed to alcohol, their hepatic enzymes have now upregulated. They say, well, we need more enzymes to metabolize this alcohol. They may be able to metabolize 60 to 80 milligrams per deciliter per hour. That is the result of the effects of alcohol causing these pharmacokinetic changes where they now metabolize it that much quicker. Okay, as the pharmacokinetic changes happen there, meaning they may have different effects of the drug because they're just metabolizing it much faster. Okay, so again, we'll get into details and when this will happen with certain drugs, when it doesn't happen. We'll talk about all kinds of different ways how kinetics can affect how drugs are going to be operating in these patients here. Okay, I'm clear on that so far. All right, and you can kind of break it down in this kind of table here where you're looking at the dose of the drug. Once we administer, and we'll talk about the different routes of administration, it has to be absorbed, and then you have this drug concentration in the systemic circulation. When I say that, what does that mean? Just in the bloodstream, right? So again, that central circulation, it just means the bloodstream essentially. It will then get distributed out to the tissues. It will get eliminated. Some of it may get eliminated from the bloodstream. And again, this is the kinetics of it, where it's going to, how it gets metabolized, how it gets eliminated. But some of that drug is going to get to the site of action. So for instance, if I give you, say, an antiarrhythmic, I give you a beta blocker, that's going to primarily work where? On the heart, right? So again, once it gets to that site of action, then it has its pharmacologic effect where you can see both toxicity and the efficacy. So for instance, if I give you a beta blocker, and we'll talk more about these later, so don't worry if you don't know this, but if I give you a beta blocker, I can slow down the heart rate, hopefully prevent a tachyarrhythmia. If I give you too much, you get bradycardia, hypotension, and you're not perfusing your organs, right? So again, everything is along a spectrum between efficacy and toxicity, okay? So there's also the concept of pharmacogenomics. Anyone want to take a stab at what this means? It's how your genes, good thing it's a Friday, you guys are all in your genes, are affecting how you handle these drugs, right? So for instance, you could have one person who of a certain lineage, of a certain genetic predisposition, they can metabolize a drug exceptionally well. They can metabolize this drug just extremely fast, so fast that they may not even get a whole lot of effect out of the drug because it gets broken down and sent out of the body so quickly. You get some people, that same enzyme could be very poorly metabolizing. It could be very slow, and they keep that drug around for a lot longer. Those levels build up, and then they're at risk for toxicity, right? So this is just the impact that your genetics are going to have on your ability to metabolize or handle drugs. This can affect both the dynamics and the kinetics maybe do one or the other. It just depends on the drug, and we'll talk more about those later on. Now, some of these you can test for, especially some of the more common ones or the ones that are much more clinically relevant we can test for, but a lot of them we may not, because again, it's such a rare group of people that may have the genetic disposition for a certain trait. It just depends, but as things get cheaper and easier, you'll see this become much more common as time goes on. So getting down to it, what is a drug? What is a drug? Are drugs good or are drugs bad? Both, yes, exactly. I think somewhere the truth is in the middle, as it turns out, right? No, I'm not trying to get philosophical, but basically, a drug's any substance that we can give to a patient to try to bring about some sort of biologic change, right? Some sort of change in function within the body itself. When I talk about drugs and I talk about receptors, that's going to be a lock and key sort of model here, right? So again, this is going to be the key that you're going to be sending in to interact with receptors. We're going to talk a lot about receptors today and the different types that we have there. Now, receptors is that component of the cell or organism that's going to be interacting with the drug, right? So, and again, this can be anything. This could be, for instance, it could be on human cells where these receptors are lying. They could be on bacterial cells. I was given an antibiotic, right? It could be anywhere. They can be on the cell surface, or they could be intracellular. We'll look at some different examples of that a little bit later on to show you where receptors actually lie. But and again, a lot of different things can be receptors here. Enzymes can be receptors. Transporter proteins can be receptors. DNA can be a receptor. Really, anything that drug is interacting with is then classified kind of as that receptor. Okay. Especially think about like DNA targets for like chemotherapy drugs and things like that. It could be a very specific example of DNA being one of those receptor types. And again, this is playing a role in regulation in terms of how it's interacting, how it's going to be affecting the system here. Now, I'm sure in physiology, you've talked about the concept of homeostasis, right? What is that? Maintaining balance. The body likes where it's set at. It does not like to change a whole lot. And so, for instance, if I cranked up the heat in here, what would you guys do in response to that? You just start sweating, or you take off your jacket. If I turn down the air, you do what? Probably put something on, right? So again, your body's maintaining homeostasis. Your body does the same thing in response to drugs as well, right? So, and again, that chronic drinker, in response to having that substance being chronically exposed to the liver, it says, well, I want to metabolize this faster. Alcohol looks like a poison to me, so I'm going to metabolize it quicker. That's a form of homeostasis, right? So receptors can change. They can upregulate. They can downregulate. They can desensitize. They can do lots of things in response to that because, again, your body wants to maintain homeostasis. And so you're going to find that as a constant theme throughout pharmacology is how we're trying to disrupt that by getting the body out of homeostasis to get them to a new set point. So an example, like what's a normal blood pressure? 20/80, right? You say, okay, well, that's pretty normal. What if I have someone who's been a chronic hypertensive and they're normally sitting at 160 over, say, 90? What is their normal? 160 over 90, right? So again, if I were to disrupt that, if I were to give them an antihypertensive and bring that down, the body's going to fight that because the body is now saying, well, that's my new normal. I want to keep it at this 160 over 90. So by giving them an antihypertensive, you're going to find there's compensatory mechanisms that will try to combat that and try to keep the body back to where it was until we set that new normal by kind of keeping them chronically at a non-hypertensive state. So again, we'll get into examples of that a little bit later on. And again, here's another picture kind of showing you the association and the dissociation of drugs along with the receptors here. And again, a drug, when it binds to that receptor, is it stuck there forever? No, it'll come back off. And again, it's an equilibrium here. Obviously, the more drug I have in the system, the more likely you are to drive the concentration or drive the reaction over to this side where the drug is bound to that complex, right? And again, you're going to find there's diminishing returns as you occupy more and more of those receptors. To a point, you're going to find the drugs just don't work any better at a certain dose. You may get more toxicity, but not necessarily a whole lot more efficacy. And we'll talk about that in the next lecture here. But again, it's important to understand this is a balance here, and the more drug I put in, the more likely I am to have those receptors occupied and get the effect that I'm looking for. Now, ligand is sort of a generic term. It's really anything that binds to the receptor, and this can include endogenous ligands, endogenous things that we produce to bind to those receptors. So as an example, insulin, you can produce insulin endogenously, right? That's an endogenous ligand to bind to insulin receptors, which will cause glucose uptake in your peripheral tissues. Or I can give it to you exogenously. I can give you different forms of insulin, say if you're a diabetic patient, in order to get the same effect there, right? Both are ligands. One's just exogenous, one's endogenous. Okay, so it's kind of a generic term we can apply to that. But again, it's involved in a lot of different types of chemical signaling, as we will see there. Again, this can include things like neurotransmitters, like epinephrine, serotonin. This can include other hormones like cortisol, Drugs, messenger molecules, any of these can be considered ligands. As long as they bind to a receptor, that's the term. When I say hormone, what does that mean? You know the term, you kind of know what it means, but can you verbalize it? Yeah, it's good. So signaling substance, get released by one organ, an endocrine organ, into the bloodstream that will travel about and then affect change in other organs. So example, you covered endocrine stuff in physio yet? You covered stuff like the anterior pituitary, perhaps? Yeah, so you know a lot about those, like TSH and things like that, right? Those are hormones that get released from one area, get sent around to interact with another tissue to induce change, right? Again, we'll see that there's a lot of drugs that can interact with this system. Sometimes we give replacements for it. Sometimes we can do all kinds of things with this. Basically, you can kind of consider it like a drug that your body's producing, since it does have distinct systemic effects. Even though it's being released from one particular organ, it can affect the entire body there. So as imagine like testosterone, estrogen, progesterone, you're going to find this is a lot of drug targets as well when we get into talking about those specific substances there. And then xenobiotic is really kind of any chemical compound that is foreign. So as an example, insulin would not be a xenobiotic, but ibuprofen would be, because it is a foreign substance to your body. Toxins, and again, you may hear me use the term interchangeably between toxin and toxicant. Toxin usually means any kind of poison of a biologic origin. So like snake or spider venom is considered a toxin. Botulinum toxin is considered a toxin because that's a naturally occurring substance. However, we use that therapeutically for what purposes? Botox, what do you use it for? To look amazing? Sometimes. We actually use it for other muscles as well. We can actually, if you have like chronic migraines, they're due to tension in some certain neck muscles. We can innervate, or we can paralyze those. Talk about headaches. We can help with like kids with CP, cerebral palsy, have spasticity issues. We can paralyze some of those muscles, right? So we can use it for different purposes, even though it's doing the same thing essentially. And we can also look good at the same time, right? A little bit for the patient, a little bit for me. Like, just kidding, don't do that. At least not the same needle. That's really gross. But again, we'll look at the harmful effects that can happen from there. And actually, botulinum toxin is actually one of the most potent poisons in the entire world. So it's just a tiny, tiny amount you're using. I mean, even like, a pinhead could probably kill a couple people in this room, right? But again, we use it for beauty, so interesting. Just interesting. Toxicants is really kind of anything of non-biologic origin. So, if you had like lead poisoning or if you had a pharmaceutical poisoning, would be considered a toxicant. In general, you'll find that the two terms get used pretty interchangeably there. But toxicology is basically just that study of the harmful or poisonous effects of substances on the body, right? And so that's why I got really into that. I actually took an elective when I was in pharmacy school. I said, wow, it's really cool, all these like drugs and like what they do in the body normally, but like what if I cranked it up to 11? And what if I mix them all together? And then that's really what I fell in love with, which is why I still do it to this day. So very interesting stuff you see with toxicology. Anyway, we'll have a whole section on that towards the end of Pharm 2 as well. So getting back to our substances here, ligands can either act as an agonist or they can work as an antagonist. Agonist just means it's something that's going to bind to and activate the receptor. Okay. So as an example, if I activate the insulin receptor, what's that going to do to your blood glucose levels? Probably going to decrease them, right? Because you'll have to see your skeletal muscles start to uptake glucose, your liver will start to take it up. That's by agonizing those insulin receptors in the body. Okay, you're activating it. This generally directly bring about the physiologic effect you're looking at. As an example, imagine a beta-2 agonist. So most people have probably heard of albuterol, right? It's used for asthma attacks, and your little blue inhaler you can use there. This is a beta-2 agonist. So when it activates the beta-2 receptors, that causes bronchial smooth muscle relaxation. So that way air can be transmitted easier, patients can breathe a little easier, right? As an agonist at the beta-2 receptor. When we're talking about how agonists are binding to these receptors here, you're going to find there's a few different terms we're going to talk about. So one of them is going to be affinity, or how strongly a drug is going to bind to that receptor. Again, not everything binds super tight, not everything binds super loose to those receptors there, but basically the higher the affinity the drug has for the receptor, the more it likes to be bound to that receptor, the longer it's going to be sticking around for. I'll talk about some clinical examples of that in a minute when we talk about some opioids in a little bit, but that is affinities, how likely or how much it likes to bind to that receptor there. Now potency, what does potency mean? How strong it is. That's kind of getting at the term. It's basically how much drug does it take in order to get the desired clinical effect, right? So if something is less potent, I have to give more drug to get the desired effect. Something is more potent, I give less drug to get the effect. As an example, so you guys are familiar with opioids, right? What do we use opioids for? Analgesia. Some people use it for getting a really good time, as it turns out. Right? We're in the opioid epidemic. It's a big problem nowadays, right? But let's look at a few different opioids that are out there. So morphine, people probably heard of morphine before, right? A dose of morphine, if I were to say you were to break your femur and you're in a lot of pain in the ER and I wanted to give you some pain relief, I would give you, say, 5 milligrams of morphine, okay? That is a dose it would take to get the desired analgesic effect for you or that patient. Now, if people heard of the drug fentanyl before. Fentanyl primarily is used in the surgical sort of setting. It's become more popular other places within the hospital, but nowadays, where do you find a lot of it? In heroin, you find a lot of it. Actually, a lot of the heroin is being now laced with fentanyl. That's why it's becoming a big problem nowadays, causing a lot of deaths. But fentanyl is very, very potent, which means I need only micrograms of it in order to get the same effect. So 5 milligrams of morphine would be roughly equivalent to, say, 50 micrograms of fentanyl. So it's a lot less drug you have to give in order to get the same desired effect. If I were to give 5 milligrams of fentanyl to somebody, they would be dead. So again, potency really matters in terms of when you're looking at the different doses between drugs. So why is this one dosed in micrograms, this one's in milligrams, and this one in grams? It has to do with the potency, how much drug it takes to get the desired effect. Okay. Looking at efficacy, what do you think efficacy is? How good is a drug at doing its job, right? So again, you can talk about drugs being having different efficacies. Not all drugs are created equal. Some may be better at reducing blood pressure than others, right? Some drugs may be better at producing analgesia than others, okay? That has to go back to the efficacy there, and we'll talk more about some comparisons there a little bit later on in this class. Clinically, what is important for you as a clinician is going to be which drugs are most efficacious, not necessarily which ones are most potent. But just know when you're looking up things like in LexiComp or looking up things like in your Terrascon or wherever you look up your drug reference, just know that we're already taking into account the potency, right? So when you look at the different drug dosages, they've already figured out the potency issues. You don't have to think about that. But you do want to be concerned with how efficacious these drugs are, okay? Because I can always adjust the dose to overcome the potency. But if a drug is never going to be as efficacious as I want to be, it's just how it is, right? It's just never going to do what I want it to do. So we'll give some examples of that in just a minute. Okay. Now, when we're talking about equipotency, this just basically means that you have two different drugs. What are the equivalent doses I need in order to get the same effect? We call those equipotent doses. And the example I gave a second ago, 5 milligrams of morphine is roughly equivalent to 50 micrograms of fentanyl, right? That is an equipotent dose. Depending on who you talk to, maybe a little different, but let's just say for our purposes there. Or as an example here, if I have 100 milligrams of drug A, let's say I get a 10 millimeter mercury drop in systolic blood pressure, but I only need 10 milligrams of drug B to get the same effect. That's an equipotent dose. Okay. Sometimes that's useful because I may have a patient come into the hospital, and then if you go into the hospital, do we have every drug on the shelf known to mankind? Why not? Because we're bad pharmacists? No, because it's not cost effective, right? It doesn't make sense to have every single drug that's out there. So sometimes we have to convert patients over, right? And I may have to give you a call and say, hey, you wrote for this, but we don't carry this. We need an equipotent dose of something similar to that we do carry. And so we make these conversions all the time, and you'll find charts and things like that can help you with it. But just know when I say equipotent, it just means they may be different doses, but they cause the same effect in the body. Okay. Now, not everything that binds to the receptor that is an agonist is considered to be a full agonist. But a full agonist means it has 100% activity at that receptor, means it activates it as fully as it possibly can. You should expect to see full effect when bound to and activating that receptor there. So it goes to say that if I have full agonists, then I should also have what? Partial agonists, yeah, absolutely. So there's also partial agonists, which means it'll have a lesser effect, even though it's still binding to the receptor the same way as a full agonist, but maybe you only get 50% effect, maybe only 70%. You're not ever going to get the same 100% effect. So in terms of efficacy, partial agonists can be more or less efficacious than a full agonist. Less, right? Again, a lot of this, kind of follows common sense there. So partial agonists would be less effective overall than a full agonist. That may be okay, right? Maybe I only need a partial effect. Maybe I don't need the full effect as it turns out. I'll give you another clinical example of that in a minute here. But again, just know that even though you may have on 100% of the receptors occupied, you may only get 50% out of that because, again, it's a partial agonist. Again, just kind of pictorial example here. So with the full agonist, maybe I get a 10 millimeter mercury reduction in systolic blood pressure with 100% of receptors occupied, versus with a partial agonist, maybe I only get a 5 millimeter mercury reduction there. Okay, even though they're 100% occupied, I only get 50% effect here. Okay. And if you're to plot this on a curve here, you'll see that response is going to be on our y-axis here. The concentration of the dose of the drug is going to be in the x-axis. You see the full agonist will always outperform the partial agonist in every case, as long as you're occupying all those receptors there. Okay, so just know that's kind of the big difference between these two. Now we have full agonists, we have partial agonists, we also have antagonists. What do you think antagonists do? They block it, right? You'd think it would do the opposite effect, but that's not really. There are something called inverse agonists. I'm not going to talk about those because they're fairly rare. But an antagonist is basically just going to sit on that receptor and prevent anything else from interacting with it. So as an example, you have beta receptors, you have alpha receptors. What do those respond to in the body? What neurotransmitter? Norepinephrine and epinephrine, right? So if I were to give you, say, a beta blocker, something that blocked the beta receptors, it'd be blocking the activity of endogenous catecholamines like epi and norepi, right? That's what they do. They're antagonists. They just sit there on the receptor and prevent those natural products from actually interacting with it and causing its effect there, okay? Or sometimes we can use this as an antidote to maybe reverse the effects of other types of drugs, as I'll show you in just a little bit. There's different types of antagonism you're going to see there that can occur. This is the most common one. This is called a competitive antagonist, where basically it's kind of a numbers game. As long as you have more of the antagonist around, you can block the effects of whatever the agonist would normally be, okay? However, if I maybe had a really big dose of the agonist, I could eventually force off this antagonist just based off the numbers, right? It's all a numbers game. That's why we call it competitive antagonism there. There are other ways you could do this too. Like, for instance, you have an allosteric antagonism where maybe the antagonist will bind to a different site on the receptor and will change the conformation of that protein to prevent the agonist from binding. That's one way to do it. You can have something like a chemical antagonism where it actually binds to the agonist and directly inactivates it. So have you guys ever heard of like drugs? You probably see a lot of commercials on TV where they end with a MAB on the end of it, MAB. Actually stands for monoclonal antibody. It's a big kind of new blockbuster class of drugs here where we're actually are designing antibodies to go up and bind natural products in the body. That's one way you could do that. It's kind of working as an antagonist by binding up and inactivating natural products in the body itself, right? That's one way to antagonize the system. And then there's what we call functional antagonism that will indirectly inhibit the physiologic actions of an agonist. And so what I mean by that is basically you have two substances that are kind of doing the opposite effect. So as an example, think about combining, and again, I don't recommend you ever do this, but combining the effects of, say, alcohol with caffeine. I've never heard of Jaeger bombs, or perhaps pre-ban Four Loko, where it still had a lot of caffeine in it. Some people laugh, they're chuckling like they had some personal experience. We'll neglect to acknowledge that. No. But it makes sense, right? Because alcohol is normally a depressant. What does caffeine do? It's a stimulant, right? They directly counteract one another, right? Or say, for instance, I have someone who is a diabetic patient who they're taking insulin to control their blood sugar, but I have to give them a steroid because they have osteoarthritis. Well, I know steroids increase glucose. They're directly counteracting one another, even though they're not really antagonists of one another, but they counteract one another. And so it could be through an indirect sort of mechanism, and they can antagonize each other. That's why it's so important. You have to really do good, thorough medical histories on these patients to get all the medications they may be taking, because you need to know about those drug interactions, right? So you decide to prescribe a new medication, you need to know potentially what's going to be interacting with, and maybe, because again, you may cause their blood pressure to be uncontrolled, their blood sugar, their asthma, anything could be affected when you have an antagonism like this, okay? But just know in general, there's going to be no activation of the receptor itself. Here's another example showing you a receptor site where the natural chemical will be coming in and binding to it. Here's an agonist that looks a little different, obviously, because it's not the endogenous product that would still cause activation. But the receptor here, the antagonist, you can imagine being kind of plugged up. So you put a cork in the receptor site, and it prevents really anything from binding to it, either the drug or potentially the endogenous product that would normally bind it, right? The endogenous ligand. Okay. Now, again, this could be a numbers game. You can have enough drug around to eventually counteract that. But again, that's that competitive antagonism I was mentioning, and that's the most common one you're going to run into in terms of antagonists out there. So there's also this term or this concept of reversibility or irreversibility. Now, in most cases, most of our antagonists are going to be reversible, right? As soon as they're metabolized and out of the body, the effect is gone, okay? Ibuprofen is a really good example of this in the NSAID category. As soon as you metabolize the ibuprofen and eliminate it, it's out of the system. It's not affecting, not affecting your body any further. However, we have irreversible antagonists that can have more prolonged effects. So as an example, baby aspirins, we normally give that to adult patients for what reason? Prevent clots to prevent what? Heart attacks, most likely, right? Maybe stroke, but mostly heart attacks, right? We call that cardiac protection. But again, you're thinking, why am I giving a baby dose of a drug to an adult patient? That doesn't make sense, right? Well, it does make sense when you consider the fact that aspirin is an irreversible antagonist, and mainly it's affecting the platelets. When it binds to the cyclooxygenase in the platelets, it will prevent it from causing aggregation, which prevents those clots from happening, which prevents that blockage of the coronary vessels. By irreversibly inhibiting the platelets, you're going to find that as long as you're giving a small dose of aspirin, basically all the circulating platelets will be affected by that, because for the lifetime of that platelet, as soon as it gets in contact with aspirin, it's affected, right? It's going to be basically antagonized for that entire period. And what's the lifespan of a platelet? We know 7 to 10 days or something like that, right? Red blood cells 120, platelets usually like 7 to 10, somewhere around there. So that means that every day you're getting rid of some of those inhibited platelets, but you're also producing new ones. By just giving 81 milligrams of aspirin, that's enough to get those new platelets affected, and let's keep the patient protected 24/7. Make sense? There's an irreversible effect. That antiplatelet effect will be around for much longer than the last dose of what I gave that patient there. Okay, even 2 or 3 days out, they can still be affected by that. As I mentioned, competitive antagonism is the most common one you're going to run into. It's all a numbers game. You can overcome that by having more agonists than antagonists. I'll give you some examples of that in a second. And then non-competitive antagonists is usually where you're going to find something's binding to another site on the receptor that changes that conformation to where at that point it's not a numbers game, it's just the agonist can't really bind to the receptor so well and it's just going to work less effectively. Okay. So if you were to look at the efficacy of a drug with either the absence or the presence of an antagonist, you can see here the agonist effect on the y-axis. Again, you're looking at the kind of the normal maximal effect of the drug by itself. When you add the competitive antagonist on board, you're going to see this is going to be ultimately limited. Eventually, by having enough of the agonist around, you can eventually get back up to pretty close to maximal effects there. But just know it's going to need a lot bigger doses of that drug to overcome that competitive antagonism. So that's one thing I want you to note with that. So this is a good clinical example here. So people are familiar with opioids. Why are opioids dangerous? They cause addiction, but physiologically, why are they dangerous? Why do they kill people? Slow your breathing, so respiratory depression, got CNS depression. Actually, the third part of that triad, you'll see there's meiosis, kind of another thing. But the really big danger is the respiratory depression. You stop breathing, things go bad pretty quick, as it turns out. So let's look at a few different agents here. So we have one called methadone. People have heard of methadone before, correct? What do you use methadone for? Hopefully to try to wean people off of their opioid addiction, right? It's a common one. It's kind of the first ones that we had that were used for that for a long time. That's a full agonist at the opioid receptor, okay? Next off, we have a drug called buprenorphine. Brand name for that is called Suboxone or Subutex. That's only going to be a partial agonist. That's also used to help with getting people weaning them off of their opioid addiction. That's only going to be a partial agonist. And then finally, we have a drug called naloxone, otherwise known as, anyone know? Narcan. What does Narcan do? It's a reversal agent. Basically, it's an antagonist at the opioid receptor. Okay. So to compare the efficacy of the three drugs here, you're going to find, again, opioid effect on your y-axis there, you're going to see that the full agonist is going to get pretty full effect out of that, right? You're going to see the maximal efficacy out of a drug like methadone. Buprenorphine is only going to have partial effects because it's only a partial agonist. And then naloxone should have zero effect because it's an antagonist. It'll sit on that receptor and hopefully prevent anything else from interacting with that. Has anyone seen naloxone ever given to a patient as an opioid overdose? What's it look like? Like The Exorcist? Can you use it to describe it? It's pretty dramatic. There's a movie called Bringing Out the Dead. It's kind of old, from the 90s, with Nick Cage and Ving Rhames. I think they're paramedics. There's a whole scene where they give Narcan to a patient. I'd recommend Googling it on, try to find it on YouTube. It's actually pretty true to life how these patients respond to Narcan. It works very well because it'll kick all that drug off the receptor and cause the person to start breathing again, right? It can possibly save lives. That's why you see a lot more police officers carrying it nowadays. That's why the Surgeon General for Florida put in a blanket order that anyone, if any first responder, can pick up a dose of naloxone from the pharmacy. We're trying to make it more available because we know it can save lives potentially. Now, why do you think I'd use a partial agonist for someone who is trying to come off of opioids? 100%, yeah. So one of the big risks of why people get addicted, part of the component of that is that when they stop taking the medication, they get severe withdrawals, right? They feel super miserable. They just want to go back to that medication, get back to normal for them very quickly. So if I can use a partial agonist, it will help to only cause partial effects, will hopefully help to prevent withdrawal symptoms, and then eventually wean them down slower. So again, there's clinical roles for all of these. Just depends on what the situation really is, okay? So again, kind of a comparison between full, partial, and then an antagonist at the same receptor, same opioid receptor. Okay. Now, specificity has to do with how specific a drug is for a certain target. So as an example of this, I like to compare antibiotics versus chemotherapy drugs used for cancer. Now, when we're giving antibiotics to a patient, presumably we're using it to kill off what? Bacteria, right? Would it be bad if we started killing off human cells as well? Yes, that would be not very specific, right? So that's why, again, we give antibiotics because they're very specific to killing off those bacteria and not our cells. That means you have limited side effects because of that specificity. Now, on the other hand, a lot of our old school chemotherapy drugs, they can't really tell the difference between normal cells and cancerous cells, which means you get a lot of toxicity because you end up killing off a lot of cancer cells and a lot of normal cells, which can lead to some of the classic sort of side effects of chemotherapy drugs, including what? Hair loss, fatigue, immunosuppression, GI issues, right? All those things come about because of the fact that the chemotherapy drugs can't tell the difference. They don't have very high specificity. Other things include tricyclic antidepressants, right? These are kind of old school antidepressant drugs. And one of the things you'll learn when you get talking about behavioral health is that all of the antidepressants have a black box warning on them. And we know what that black box warning is? It's like the really scary thing the FDA makes them put on there to be like, hey, you got to watch out for this. It's actually increased risk for suicide. Does that make sense? I give an antidepressant, it causes people to commit suicide. Kind of does a little bit. We'll talk about that a lot more later. But it's one of those things where the tricyclic antidepressants, they are super, super dangerous because it's not only that they affect just serotonin, they affect so many other systems that they become extremely dangerous in overdose. Even taking 2 or 3 times a dose can be potentially really, really dangerous, right? Well, now we have more specific drugs. Anyone know what we normally use for depression nowadays? What class? SSRIs, right? It stands for selective serotonin reuptake inhibitor. Selective is right in the name because it is so specific just for those serotonin receptors, they end up losing a lot of toxicity. And so if someone overdoses on an SSRI, I'm much less concerned about that patient than if they'd overdose on a TCA. Sometimes I talk about my sphincter tone in terms of how worried I am about something. For an SSRI overdose, I'm maybe like a 4 or 5. For a TCA overdose, I'm like an 11 or a 12, right? It's not good. But it goes to the specificity, right? It's that kind of factor. So typically we like drugs that are more specific because they limit a lot of those toxicities, right? That is kind of the trade-off we're going to get with that. And we'll get into more of those specific examples a little bit later on, okay? Now, stereochemistry. Anyone remember this from their orgo classes? Yes, ma'am, you have a question? Yeah, so remember we talked about racemic mixtures, and then there's enantiomers, and I see some people having like this Vietnam-esque flashbacks in their minds. Oh gosh, I'm not going to delve super deep into this, but just remember that normally chemicals come in a racemic mixture, which means a 50% left-handed version of the molecule, 50% right-handed version of the molecule, right? Racemic mixture. Well, what happens if I separate those drugs out? In some cases, you're going to see that we have done that. And the idea is that hopefully you can get the one version of the drug that causes all the good effects and hopefully minimize all the bad effects. So if you ever see a drug that starts off with like Dex or Levo or Des or anything like that, that is typically going to be one of these enantiomers. And one of the important things to note about this is what the equivalent doses would be of one of these enantiomers, right? So again, as I mentioned, the racemic mixture is 50-50. So presumably if I have 10 milligrams of a racemic mixture, that means I have 5 milligrams of the left-handed and 5 milligrams of the right-handed version, right? Everyone with me so far? So let's look at some examples here. I mentioned albuterol is used as a beta-2 agonist for asthma versus levalbuterol. It's the left-handed version. 5 milligrams of albuterol is equivalent to 2.5 milligrams of levalbuterol, right? Makes sense. This becomes clinically important because if I have a patient who's being admitted and they're on 2.5 milligrams of levalbuterol at home, but my hospital does not carry levalbuterol because it's ridiculously expensive, then I will have to convert them over to 5 milligrams of albuterol to get the equivalent dose. Make sense so far? What if I have a patient who's on an SSRI citalopram, or they're maybe on escitalopram, right? It's an S enantiomer there. Again, 20 to 10. The racemic mixture is always going to be double of what the enantiomer is, okay? And then let's say, for instance, cetirizine or Zyrtec. Anyone familiar with that drug? Yeah, it's like life-saving stuff if you have allergies. There's levocetirizine or Zizal came out. And it was 5 milligrams of that would be equivalent to 10 milligrams of Zyrtec. You think, wow, this is really great. We should do this with all kinds of drugs. Well, we don't really know a lot of times if there's any benefit to actually doing that in the first place. And so I like this the Zizal advertisement. I always thought this was really funny because it says wisely designed to be different. And you're like, wow, that's really smart. It's the active enantiomer of Zyrtec with no dextrocetirizine. Cool, that must be really good, right? Must be the really good version of Zyrtec. And you look at the bottom, it says the clinical relevance regarding absence of dextrocetirizine is unknown. So what was so wise about what you did? Like, I don't get it. However, when we talk about drug development, we talk about patents. Guess what? Whenever you have a new chemical entity, you get a brand new patent and you have a brand name drug, which means you get more money. I might be a little cynical, so don't let my jadedness affect you yet. But you'll start to see some trends. Just follow the money. You'll see where it's going. Anyway, so there's a concept we were talking. You're talking about receptors and activating them or inhibiting them. One of the things we're going to look at is a concept called downregulation. This is something that happens when you're constantly activating a receptor. And again, this is part of the homeostatic mechanisms, right? It says, well, I'm getting too much activation at these receptors. How could I decrease the activation? Well, I could decrease the number of receptors that are at the cell surface. And that's one way to do that. That way you kind of diminish the physiologic effect of the drug on the body there. And so typically that's going to happen with the effect of agonist. When you're overstimulating the receptors, they will then downregulate. Okay? Now, what happens if you're blocking receptors chronically? You'll see that, hey, well, there's not enough activation here. How can I get more potential activation? It's the upregulation of those receptors. So typically, antagonists will cause upregulation of receptors. Agonists will cause downregulation of receptors. The whole point is to try to get back to the normal, whatever the body was at normal baseline. It's part of that homeostatic mechanism. Okay. We'll talk more about that a little bit later on. Another concept here is one called bioavailability. This just means how much drug or how much percentage of a drug actually gets into the systemic circulation after administration. Now, this is very route dependent, meaning if I give a drug via the rectal route or the oral route or the IV route, they may have different bioavailabilities. And there's a lot that goes into this, including things like liver metabolism and things like that. And we'll talk about the different amounts of bioavailability based on route in just a few slides here. You'll see that intravenous could be 100%. It's going straight into the veins. That makes sense. Versus oral, it could be anywhere between 0 all the way up to 100%, depending on the drug. So we'll look at some examples of that. Now, first pass is an effect that we talk about in terms of oral dose administration. Now, once a drug gets into the GI tract, goes through the stomach, and most drugs tend to get absorbed from the small intestine. Now, what's the first organ it's going to hit after it gets absorbed from the small intestine? Typically the liver, right? Most things are going to hit the liver as they go through the intestine, hit the liver, and then get into the venous blood supply. Okay. Now, the liver is really important in terms of drug metabolism because it's the main site for most drug metabolism. So that means that for some drugs, some of that drug is going to get metabolized as it gets passed through the liver before it makes it to the bloodstream. Okay. That may be a lot of the drug, could be 100% of the drug, or it may be 0%. How much of it gets through is considered that first pass effect, right? Or how much of it gets metabolized, I should say. I call this the liver tax because basically it's going to be a percentage that you're going to have to give up of the drug as it passes through the liver to make it into the central circulation. Okay, and as I mentioned, some drugs have so much first pass you can't even use the drug orally. Some drugs have 0 first pass effect. So we'll talk about some examples of that later on as well. Now, a concept that goes along with first pass is considered this term called prodrug. Now, this is delineated from amateur drugs, which don't work as well. Just kidding. No. A prodrug basically just means it is a drug that is in its normal form is inactive until it goes to the liver and gets metabolized into the active form. Okay, so normally if I were just to give the drug IV that way, it doesn't get past the liver first, and so it's going to remain largely inactive. But by giving it orally, it'll go through the liver, it gets converted over to the active form, and thus now it works like it should. A good example of this is a medication called Vyvanse. Anyone know what Vyvanse is used for? ADHD. It's a very popular ADHD medication nowadays. Originally, when it was kind of designed, one of the purposes of it was that we used to have things like Adderall and Ritalin and Concerta. I mean, we still have those drugs. But one of the things people would do is they would take these tablets and they would crush them up and they would snort them because you get a pretty good high off of amphetamines, right? Because it causes a lot of release of catecholamines and dopamine and all kinds of good stuff, right? It's not really good stuff, but they feel really good when they do it. So they said, well, is there any way we can deter this sort of abuse for some of these patients who are maybe at risk for this? And so they came up with a prodrug. So you have lisdexamfetamine, and if I were to say crush up and snort a tablet of Vyvanse of lisdexamfetamine, which is not active, you really wouldn't see a ton of effects from it. You'd be like, oh, this is kind of crummy, wasn't very good of a high. However, if they were to ingest it, it actually gets passed to the liver, converted over to the active form of dextroamphetamine, and now it has this mechanism. Now it can work on ADHD and helping you to focus and study for longer and better and all that kind of good stuff, right? So again, that is an example of a prodrug, which is inactive, but gets converted by the liver into the active form, okay? Volume distribution is a term we'll talk much more about in the pharmacokinetics section in a couple of lectures, but basically this is how distributed out a drug gets into the tissue. As I mentioned, drug normally is first going to enter the systemic circulation, and then from there, how far out it gets distributed is that volume distribution. Some drugs love to go out into the adipose tissue. They love to go out into the tissue and just stay there. Some drugs prefer to stay in the central circulation. A lot of it depends on the lipophilicity of a drug. And remember what that means? How much it loves lipos? How much it likes fat, right? How fat soluble the drug happens to be. More things that are more lipophilic, more fat soluble, tend to distribute out further. So a good example of this, you think about urine drug screens, you worry about testing positive for THC. THC is normally found in what drug? Marijuana, right? THC is extremely lipophilic. That's why you like to cook with it. That's why you put it in brownies and cook it with your pizza and all kinds of stuff, because it's very lipophilic, right? It'll actually partition in things like butter and oil very easily. Some of these might just be new information for us, so I apologize if I'm like giving you bad ideas or anything. But I'm not saying you should do it. I'm just saying this is why this stuff ends up this way. But anyway, so THC is very lipophilic, though. That means if you have someone who's a chronic user of marijuana, you're going to find that THC likes to distribute out to the adipose tissue. That is why. Does anyone know how long you normally stay positive on a urine drug screen for THC? A couple of days, not a year, not that long. Sometimes it can be like a couple of weeks, right? It can be up to maybe 6 weeks in some cases, maybe up to 2 months, depending on the chronicity of use, depending on how much adipose tissue the patient has, because it just likes to stay out there in the tissue, and then it'll slowly leach back out into the bloodstream and eventually come out in the urine. So again, it goes to show you that it's a very lipophilic substance that likes to have a very large volume of distribution. We'll talk much more about that a little bit later on, okay? So getting into routes of administration. So two of the big delineations we'll talk about here in terms of administration is that we'll have enteral and parenteral administration. Enteral just means what, if you had to guess? Oral, right? So anything taken orally is typically going to be considered enteral. So you have like enteral nutrition, is like anything you eat at lunchtime, right? Parenteral means anything you're going to be given via injection. This includes your sub-Q, your intramuscular, your IV, anything given via needle typically is going to be considered a parenteral route of administration. Okay, so it's kind of one delineation I want to note here. Now this table is very handy because it kind of will compare and contrast the different forms here. And I just want you to note that one, you don't have to memorize the actual numbers in terms of bioavailability. It's concepts I want you to get here. So for example, you should probably know that IV is going to be 100% bioavailable because again, you're putting it right into the bloodstream. That makes total sense there, right? Versus something oral could be anywhere between 0 to maybe up to 100% bioavailable. And then the characteristics are good to note here as well in terms of the onset of action. If it bypasses first pass, if it's painful, things like that. There are some concepts we're going to be talking about here in the next upcoming slides. This is a good kind of summary slide to go back to, okay? Now, starting off, we have the IV route of administration. This is good because it is the fastest way you can get drugs into the system, and it works fairly quickly, right? What are some of the disadvantages to using IV medications? Are there any? You need to get an IV to start with, right? Who are difficult patients to get IVs on? Elderly, dehydrated patients. Who else? Children, yeah. Imagine you have a 600-gram neonate who's coming in to your hospital, right? Trying to get an IV on those little tiny fragile veins, like it can be really, really tough, right? So getting the IV can be a really tough challenge. What are some other negative sides to IVs? Yeah, once you put it in, you can't get it back out, right? That could be one thing. What else? Infection is another big one, right? Anytime you have foreign material in the body, whether it's a urinary catheter, whether it's an IV catheter, you run the risk of infection, right? So those are the big concerns we have there. Other things you have to worry about. You have to worry about precipitation of substances, right? That's why oftentimes you may not be thinking about it, but your nurses are about, okay, can I mix these two drugs together? Here's an example. If you were to mix calcium and phosphate together, it forms this precipitant. What happens when you inject that into the patient? start causing emboli, right? You can cause the lungs to have an embolus form there. You can cause the vein to take some damage there. You can lose the IV line entirely. Lots of issues seen with that, right? So again, you have to worry about things like the actual compatibility of substances together, as it turns out. Okay. The advantages, though, very fast onset, very quick. Also, we can consider this titratable. So we can either give drugs intermittently, right? So you can give it intermittently in terms of like, I'm going to give this drug every 12 hours or every 8 hours, say over 5 minutes, over 30 minutes. Or you can give it via continuous infusion, meaning the drug's going to be running 24/7, right, until you stop it. It's titratable because I can turn that dose up or down depending on how I want the drug to work. So let's say, for instance, I was giving epinephrine via continuous infusion for a patient who's hypotensive. I can give them a dose of the drug, and if it turns out now their blood pressure is too high, what do I do to the drug? Turn it down a little bit, right? If it is too low, titrate it back up a little bit, right? It's titratable. That's kind of the nice thing. However, if I give a big bolus dose of something and I go, oops, that was the wrong drug, can't really get it back, right? Now it's in the system, now I got to deal with that. Also, when we're looking at this, again, it's 100% bioavailable. That's great. And then we also have this consideration of whether it's central versus peripheral administration. Now, when I say that, does anyone know what I mean? Has ever heard like central lines or peripheral lines? What's a peripheral line? Anything in the extremities typically is considered to be a peripheral line. Like the AC is a very common one, but the issue with that is that the veins are usually smaller. There's usually less flow there. You have to worry about things like thrombophlebitis. You have to worry about things like extravasation. Extravasation means you accidentally blew the vein and now drug is going out to the surrounding tissues. Here's an example of someone who has what we call purple glove syndrome, of someone that extravasated the anti-seizure drug phenytoin. That is a lawsuit waiting to happen. One way we can get around that is by using what we call central access, where usually you'll have something like a peripherally inserted central catheter. It's called a PICC line, if you've ever heard of a PICC line before, where it'll be inserted to a peripheral vein, but it'll travel, snake its way all the way up into the vena cava. What's the benefit of going into the vena cava, do you think? All that blood is flowing right there, right? It's all about to go into the right side of the heart, so it gets very dilute very quickly. I can run higher concentrations of drugs. I can run more drugs through. That's what if you ever hear like a triple lumen catheter or things like that, those are typically, or ports being placed, those are typically central access, and it allows for us to give larger doses of drug, more concentrated forms, etc. Okay. So anyway, so those are the big things to consider when you're thinking about IV administration, but very fast, very common, especially on the inpatient side of things. Now, what if you couldn't get a vein? Let's say we're going back and we had that 600-gram neonate, right? It's very, very tiny and fragile. You couldn't get an IV, but we have to give medications to that baby. What are we going to do? Well, we have intraosseous administration. This is done frequently in kids or other patients you can't get access on. And basically what we're doing is we're using the bone marrow as a non-compressible vein, essentially. So typically we'll use one of these things. This is called an EZ-IO. Ever seen one of these? I guess I should have asked earlier. Who are my EMS people? Like ER people. You seen the EZ-IO ever used before? Yeah, so again, this is a fairly common one you're going to see out there, where basically you have a little power drill and you'll attach this kind of thumbtack looking thing on the end of it, and you just drill down right to the bone. Most people are like, ooh, that sounds horrible, but I guess it's not supposed to be much more painful than a normal IV stick, but I will not test that out to find out for you guys. But anyone know where you normally would place an IO? Tibia is probably the most common one I've at least seen, because the sternum, the humerus, there's different places there. That chart kind of gives you an idea. I'm not going to have you memorize that chart there. I just want to give you an idea where you could use those potentially. But again, it's nice because I can give full doses of medications. I can give IV fluids through that. I can do anything I need to do as I would with a normal IV line, which is great. So very useful in emergent situations. You may find that like a patient rolling into the ER has had one placed by EMS. You may find that used in some situations there. I remember one patient we had who unfortunately had died, but we were trying to take the IO out so that way get the patient kind of cleaned up and ready for the family to come in and see the patient. And unfortunately, that little plastic piece came off, and so then we had this nice like piece of metal kind of hanging out of the patient. We're just like, how do we get that out? And so like find some pliers and you can get it on out. Patient didn't feel a thing though. It's okay. Like, but I'm just saying like. These are some of the things you run into in medicine. Medicine's kind of grody when you get down to it. But things to consider. IO, very nice administration route if you have an inability to get a vein. Okay. Now, other routes of administration. Now, do you think most patients are able to give themselves their own IV? Not unless they're pretty good heroin users or something like that, right? No. Typically, no, it's not something we educate patients on. But sub-Q administration is very good for patients to do at home, right? We can do this for things like insulin. We can do this for things like anticoagulants if they need to be on those chronically birth control. Sometimes we'll actually have like slow release implants we can place under the skin. This is very nice for that. It has high bioavailability, because again, it's going to get just absorbed passively through the sub-Q tissue into the systemic circulation. And it's good for self-administration, as I mentioned. However, it's going to be a little bit slower onset than IV, definitely slower than that, a little bit slower than IM administration, as we'll see there. And again, I put the abbreviations there for your use when you're actually writing the scripts. That's how we're going to be seeing that written typically. Okay. The disadvantages, though, is you want to make sure you're rotating the site and not using the same one over and over again, because of the fact that you can see things like tissue necrosis can happen there, fibrosis can develop at those sites, so you want to make sure you rotate it around. Okay. IM administration is good for things like certain antibiotics. We can do this for vaccines, things like that. Typically, it's a little bit more invasive than the sub-Q. However, one of the big things to note with this one is you have to consider the volume that you're actually administering with this one. So because you're injecting into the muscle, you don't have a whole lot of room for expansion. Otherwise, you're going to get a lot of pain associated with this. So this is something where we have to use more concentrated forms of the drug to make sure we're not going to be causing so much volume for the muscle to expand, causing a lot of pain. Usually no more than 3 mLs can be injected for a good period of time. The other disadvantage, though, is if you have a hypotensive patient who may not be perfusing the muscles so well. Because again, if you think about it, if you're hypotensive, your body preferentially wants to keep perfusing what 2 organs? The brain and the heart, right? Those are the 2 things that you really cannot go without. We can replace your kidneys. We can do other things for your other organs, but we really can't fix the brain or the heart, so to speak. The brain especially. But so because of that, if you're hypotensive, your skeletal muscle doesn't really get as much perfusion as it's used to. You may not get as good of absorption. So that can sometimes affect the bioavailability of IM and medications there. Other things may affect us, like heat can affect absorption, exercise, whatnot. Sometimes patients with the extremes of weight may have some issues there as well. I'll tell you an example. Back when I was in school is when pharmacists were first starting to get the ability to give vaccines. And so we had a lab where we're actually doing IM administrations. And so I had the instruction was, okay, well, if you go in, you accidentally hit the bone, patient's not going to feel it, but you'll feel it. Just don't make a face. I said, okay, that's easy, right? Whatever. So anyway, so my partner in the lab was there, and so I did it, and I felt the bone being hit there, and I was like, ugh. And she goes, you hit the bone, didn't you? I was like, and she goes, it was a very odd sort of thing there. And fortunately, I never gave another injection in my life, so it's perfect. So I don't work retail, so I don't have to do that. So anyway, so that is one thing to consider there. Very, very easy administration. You don't have to worry about finding a vein or anything like that. Okay. Different injection sites include things like the gluteus maximus, deltoid, etc. Okay. Intrathecal administration. Now, when you think about things being given via the intrathecal route, anything come to mind? But pain meds for labor, right? This is a very common one you're going to see there. This is the case where we're actually directly infusing medications into the cerebral spinal fluid, right? So just like you get an LP or a lumbar puncture for a patient, we're basically doing the same thing here, except we're leaving a catheter in place to infuse drugs through. You can do this with things like chemotherapy for cancer patients. You can do this with things like antibiotics. More often than not, though, you'll find this for anesthesia. The nice thing with this route is that you can get sort of localized anesthesia based on how high up the spinal column the drug is actually getting. So for instance, when you're having a patient who is in labor, about to give birth, where's a lot of that pain going to be happening at? Probably below the waist. So I don't necessarily need their whole upper body to be numb and without pain, right? Because they're not having any pain up there. So by giving it to it and positioning the patient appropriately, you can get just the right amount of anesthesia right there at the site where the pain's actually occurring, and they can still be awake and functional and not have to worry about sedation and things like that. So it's one of the very handy things you'll see being used there. We'll use things like local anesthetics, opioids, all kinds of things to be used there. Placement's really key because, again, if you were to accidentally place that incorrectly, that can lead to things like systemic administration of the drugs, which sometimes we don't want. It can lead to other issues there. And then the most common side effect you're going to see with this is what we call spinal headache, which can happen after a lumbar puncture has been done. You'll see patients develop headache, pretty severe headaches a couple days afterwards. Next, we have sublingual, which is basically underneath the tongue here. You'll find a pretty small number of drugs will be used sublingually. If you had to think of one, probably like nitroglycerin is probably a very common one for patients with chest pain. Another one I think about a lot is patients who are coming into the ER with nausea, vomiting. Typically, they don't want to swallow anything because it may trigger more nausea, vomiting. So we'll have things like Zofran or ondansetron sublingual. If you ever see something called an ODT, that stands for oral disintegrating tablet, that is usually something that is absorbed sublingually. Okay, most drugs don't follow, are able to be absorbed through this route. So again, as I mentioned, it's a pretty rare case you're going to be able to use that. Okay. Next, we have oral. Now, this is, again, probably the most ubiquitous route of administration you're going to find. It's very safe, very common, most economical out of the bunch because, again, it does not require any kind of specialized equipment or training to do so. Disadvantages, though, requires patient compliance. What do you think that means? They need to tolerate the actual thing there. So, for instance, if I say, here, 2-year-old, please take this giant amoxicillin tablet, they're going to say, no. That's what toddlers do. So oftentimes you have to think about the formulation of it, right? So for instance, with children, we have to have liquid formulations available for most of our medications we're going to use for them, right? They have to be able to swallow. This can be an issue for patients with, say, a previous stroke or Parkinson's or have dysarthria. That can be really tough for them. And so they may need things like liquid medications, okay? Think about things like food-drug interactions that can come about from this, right? So for instance, say I have a patient who's coming in, say they have a pneumonia, and I want to treat them with a fluoroquinolone. It's a kind of antibiotic that I can use for that. So I can give them Cipro or Levaquin. Some people have probably heard of those drugs before. Well, they come back in a few days later, and they still have the same infection. They still look just as bad as they did before. I'm like, man, what's going on? Say, are you taking the medication like you're supposed to? And I say, yeah, I'm taking it just like you told me to. Okay, what's going on? So I say, well, how are you taking that? Do you take it with breakfast? Do you take it without food? What do you do? And they, oh, yeah, I take it with a big glass of milk. One of the things you'll find, because again, old people drink a lot of milk because they worry about osteoporosis, is that the fluoroquinolones will directly bind with the calcium in milk and prevent it from ever being absorbed. So you may find that patients are compliant, even though they have a food-drug interaction, it's actually preventing it from being absorbed, and it's not going to work that well. Okay, so something to consider. There are different types of oral dosage forms that are available. So we have things like enteric-coated drugs. Anyone know what that means? Yeah, so it's going to have a coating that protects it from the stomach acid. So because you're going to find that the acidic solution of the stomach may be able to metabolize certain drugs. And so by enteric coating, it's going to be able to bypass the acidic environment of the stomach. Once it gets into the small intestine, it becomes much higher in pH because you have a lot of bicarb being secreted by the pancreas. And you're going to find that will then melt off that enteric coating and then allow the drug to be absorbed. So that's one thing you'll see with that. And then there's controlled release preparations. You'll find there's a lot of different varieties and names for those. They may be long-acting, controlled release, extended release, sustained release. All of them basically mean the same thing. They're designed to release the drug throughout the GI tract over, say, a 12 or 24-hour period of time. Okay. One of the things to consider with enteric and controlled release preparations is that you do not want to crush or chew these typically, because what do you think that's going to do? It's going to break the formulation, right? So it either means all that drug is going to get dumped at once, or it's not going to have that enteric coating, and the drug will be destroyed in the stomach acid. So there's usually going to be a list of drugs you do not want to crush or chew. I recommend looking that up when you're prescribing long-acting or enteric-coated medications for your patients to make sure that's not going to be an issue for them. Okay. What do you think the benefit of using a controlled release preparation is? Yeah, so you have to give fewer doses and maybe only give a drug 1 time daily rather than 2 or 3 times daily. What's the benefit of that? Better compliance, right? I'm a pharmacist and I can barely take a multivitamin every single day. If I can't do it, then most patients probably can't do it either. So anything you can do to decrease that pill burden and make it easier for them is going to be better, okay? So compliance is a huge thing we'll talk about as we get into these specific drugs, okay? We also have the rectal route, right? So what are the advantages here? This is good when patients cannot take oral medications, right? So this is in the case of, say, for instance, you have someone who is very nauseous and is going to throw up if they have anything into the mouth, right? This is where a suppository can be very useful, right? So you've ever heard of like a Phenergan suppository? That's a common one. Usually things like acetaminophen can be given rectally, especially for like neonates who are not able to, or infants who are not able to take oral medications too easily. The nice thing about this is, one, you have very good absorption from the rectum because it's very highly vascular, right? You get a lot of blood flow there, and it's a relatively thin mucous membrane. You can absorb things very easily. Also, you bypass some of the first pass effects. You actually get more of that drug into the circulation than you would otherwise because it bypasses the liver to some degree, okay? There's some benefits there. Normally, the suppositories are going to be in this sort of, it's like a cocoa butter sort of base here. It'll come in a foil package, which please tell the patients to take the foil package off first. Otherwise, it's a literal pain in the butt to administer. Okay, so take that off first and then allow that to melt down and then it will absorb. Okay, so what do you think are some concerns when giving that rectally? Well, what if it comes back out, right? So think about like little infants. Oftentimes they have a lot of contractions related to that. Anytime the rectum is expanded or it feels that pressure, you typically have a reflex to defecate. So sometimes you have to make sure when you give it, make sure to insert it deep enough, and then sometimes you have to hold their little cheek shut to make sure they don't spit it back out at you. Little things like that you have to think about because you have to give it time for it to melt and then to absorb. Okay. Don't laugh about potty humor. Okay. This is serious stuff we're talking about here. Anyway, you see an example here of a patient self-administering it, or you could have another healthcare provider administering it to the patients for them. But again, think about compliance in terms of like, little kids, like they may not really have a big of an issue with it, versus if you're trying to give a teenager a suppository, they're probably not going to like that too much, right? Older patients may not care as well, things like that. Yes, sir. Couple of minutes, yeah. Usually, if you can, especially like an infant, if you hold their cheek shut for like maybe 2 or 3 minutes, that's probably enough time for it to kind of melt, and then you don't have to. You're less likely to see it kind of get a return on your investment there, so to speak. It is what it is, right? Okay. Another route of administration is common is inhalation. The advantage here is that you get drugs right to where they're going to be working at. The benefit of avoiding systemic circulation drugs is that you limit some of the side effects you're going to see with that. So a lot of asthmatic medications can be given via the inhalational route because, again, we want them to work just right in the lungs, okay? And again, you can see very, very fast absorption of certain medications there. That's why crack cocaine is such a problem. Anyone familiar with crack cocaine? Basically, it is the freebase form of cocaine, where it's been turned into this nice little rock that can be heated up and smoked. Right? Normal powder cocaine cannot do that. It actually destroys the drug if you try to heat it up, which is why it's typically snorted. And we know the fancy medical term for snorting. Insufflation, right? So it's not like a fancy French dessert. It sounds like it, but it's not. But you can't do that with powder. You can't smoke powder cocaine. So they have crack cocaine, and by absorbing it through the inhalational route, you have such a vascular bed of mucous membrane for it that absorb through, and then it goes right back to the heart and right to the brain. So it has very fast onset. And again, working in, I did my training in Shands Hospital up in Jacksonville. So right there in Duval County, right there on 8th Street, like you saw a lot of cracked chest pain coming in. It's very, very prevalent down in that area. And so again, because it just has such a fast absorption, has a lot of addiction associated with it. So sometimes you'll see illicit substances being used via that route because it is such a powerful high. But disadvantages, this is really, really dependent on patient technique. If they're not using this appropriately, you're going to find the drug's not working that well. So as an example, here's an albuterol inhaler, has a propellant in it. If the patient uses it inappropriately, most of the drug is probably going to end up in the back of their throat and they're just going to swallow it. It doesn't really do anything in the GI tract. But by teaching them good technique, they'll get good bioavailability, they'll get a good amount of the drug, and it's going to work better for them. Okay. There's a lot of different forms you'll see here. Here's an example of a metered dose inhaler. Now, again, this is probably a bad technique. I wouldn't want to spray it out here. But you get the idea. But there's a metered dose inhaler that actually has a propellant built into it. That's the typical asthma inhaler you typically think of, albuterol. There's also what we call dry powder inhalers. So this is actually, usually if you ever see like an Advair discus or a discus kind of medication, that is something where I actually have dry powder and the patient provides the inspirational force to get the drug into the respiratory tract. And then there's also nebulization. Anyone know what that is? Yeah, basically you have a machine, a compressor, that will be able to nebulize the drug that's in a cup, and then will kind of come out as a general mist. And again, you're going to find it's kind of the shotgun approach, where the patient's just going to kind of breathe it in sort of passively. A lot bigger dose with that, but you're also going to see a lot more side effects associated with it. Yes, sir.
I've heard that like the Advair MDIs are a little bit, like they're just better than the
DPIs.
Powder. Mm-hmm. Yeah, but the DPIs are much more common.
Mm-hmm.
Why?
I think it was the first one that came out. I think, and so it's probably just more ubiquitous, and people are kind of providing it or just writing for it more frequently there. All of it depends on which one's better or not. It depends on the technique, though, for sure. So, if a patient is not able to really kind of breathe in on their own forcefully enough to get the powder in, that's not going to work for them. They're going to need something that has a propellant built into it. The problem with the propellant, though, with the metered dose inhaler, if they can't coordinate pressing that canister when they're breathing in, then it doesn't work. And also, like, what if they have osteoarthritis in the hands or rheumatoid arthritis? You don't have the dexterity to do it. It's not going to work for them, right? So again, there's a lot of considerations that go into it. Maybe a nebulizer is better for a patient like that. Little kids oftentimes have a hard time coordinating that, so we also will use nebulizers for them as well. Yeah. Anyway, so again, there's other routes. Oh, yeah, I forgot to put this in here. But yeah, so again, this is good about the teach-back method. Let's see if I can get it to play. So you ask the patient, show me how you use your device. How do you actually take your medication here? And you're like, oh, that's why it doesn't work. Like, oh, perhaps they're compliant, but they're not using it appropriately, right? I've given this face way too frequently to too many people out there in the medical world. But it's one of those things like, oh, right, okay, that's why it doesn't work. Gotcha. But that's a good opportunity to teach back, right? Because I can blab it, blab at a patient, or I can blab at students all day long. But if I have you actually teach something back to me, then I actually know that you know it, right? So it's an important technique there. Anyway, other routes include the transdermal route of administration. This is a way to get drugs systemically administered through the skin, essentially. And we'll talk about how this works in terms of permeability and passive diffusion and all of that. But basically, you'll have a patch that has a large amount of drug in it. Large amount of drug in this patch here, and then via passive diffusion, it will then go through the skin and get into the systemic circulation. You'll sometimes see things like anyone ever been on a cruise and they have like a little transderm scope, they put it behind their ear to help with motion sickness? There's that. There's like fentanyl patches. There's lots of different varieties of things that you can use through the skin. The caveat is it has to actually get through the skin, right? So something that is lipophilic has an easy time going through. Things that are not lipophilic have a harder time, right? So these are things to consider. Yes, sir.
Why do some drugs only go down to like the dermis to get into the bloodstream versus some that go sub-Q?
I mean, why do you have to administer some drugs subcutaneously?
Sure.
Yeah, because you have that stratum corneum is can be very difficult for drugs to pass through. So, for instance, something more hydrophilic may be better to place into the subcu tissue where they can absorb passively more easily than it would be able to actually get through the skin. Yeah, we'll talk more about that when we get to the derm topics in Pharm 1 next semester. But yeah, so it's very drug dependent and a lot of factors into it. Yeah. But again, the nice thing here is that a lot of these have a nice controlled release for several days. So sometimes you only replace them once daily, every 3 days, every 7 days. Depends on the patch there. Problem though is that, again, not all drugs can penetrate. And then also you don't want to use it on things like open wounds because you may have too much absorption occurring there. And then also there's still a lot of drug left over in those patches when you're actually done with them. So one thing you'll see is that people throw them in the trash, and then who likes to go through the trash and pick things out? Either animals or children. They're basically the same thing anyway. But so you'll find they'll go and pick it out of the trash, they'll eat it, and then they will end up getting toxic from that. I had one kid, he's probably like a 10-month-old that came in, and basically he came in, he looked like he had an overdose of a drug called clonidine. He's very sedate, his blood pressure, heart rate was kind of low, and we're trying to figure out what the heck was going on here. And so I was talking to the family, and I was like, hey, what medications do you take? And Dad was like, oh, I take clonidine patch for my blood pressure. And I said, oh, that's interesting because this looks a lot like a clonidine overdose. Is there any chance that he could have eaten one of those patches? And he's like, no, there's absolutely no way. Not possible. Can't even really get around that well. No way he could have gotten into that. I said, okay. I said, are there any other children in the house? And he goes, yeah, he's got an older brother. He's like 3 years old. I said, okay. I postulated that the older brother probably picked it out of the trash and gave it to the little one, right? I've seen my daughter do it now. I have a 3-year-old and a 1.5-year-old, and I've seen her do it. Like, give her little Cheerios, and she's like, here you go, baby. And the baby's like, stop. And she's doing it anyway. So I postulate this is probably what happened. And sure enough, that kid, two days later, pooped out a patch. So again, sometimes you have to go with what you think might be likely based on the kind of the environment there. But anyway, that is a risk for poisoning with those patches because they have just so much drug still left over in there. Anyway, there's other routes available as well as ocular, oral. Oral just means what? In the ear. Otic is another thing you'll see used there occasionally. Mucous membranes, you can administer things via the vagina, urethra, nasal. We'll talk all about those when we get to those specific instances in the coming semesters. Okay. So about drug development real quickly. How did new drugs come out on the market? Anyone know? Talk about the FDA. Ever heard like phase 1 trials, phase 2, phase 3? Yeah, that all kind of goes into it. And basically the Food and Drug Administration are kind of the arbiters of what drugs get put out onto the market there. I won't talk too much about herbal supplements, but just know that is something completely separate. And the FDA does not really have a whole lot of oversight on those. It's not to say they don't work. It's not to say they're not good. It's just they don't have as much oversight as the FDA does, right? They don't have as much control over their manufacturing and production of those things. But medicinal products sold with a prescription or over the counter do fall into this caveat here. And so again, they're made to be safe and efficacious. They can't prove that, and then the FDA is not going to put them on the market. So again, there's several acts that came about, and again, why do we have a lot of these laws in place? Usually because some sort of tragedy happened here. So as an example, there's a case in 1938 where this elixir sulfanilamide, it was an antibiotic that was administered, actually contained a product called diethylene glycol, extremely toxic, caused several children to die. So that caused a new act to come about. So now we have the Food, Drug, and Cosmetic Act, right? Other things like, anyone ever heard of the drug thalidomide before? Anyone know what it's kind of notorious for? Yeah, kind of like these like flipper sort of appendages were produced. Essentially, thalidomide was used for pregnant patients in Europe. I don't think there's any, maybe very few documented cases here in the U.S., but it was something used for pregnancy-related nausea, vomiting, and actually found these babies were being born with this limb angiogenesis, where basically, and angiogenesis, where they basically were having the limbs were not developing correctly, and they had kind of these like flipper-looking limbs. And so because of that, it's called teratogenicity. It's a teratogen. We said, okay, we're not going to allow these to be used over here in the U.S. So now we have to do things like animal studies and whatnot to try to prove that drugs are safe and effective, and we're not going to have tragedies like this being happening again. So anyway, so again, I'm not going to ask you about specific laws. I just want to kind of give you an idea of kind of what happened that it spurned a lot of these to produce the system we have nowadays. So basically, there's 3 clinical phases and 1 post-marketing phase that come about from any drug trial. And there's some good graphs here in a second I'll show you that illustrate this. Basically, when a drug company has, they go through their preclinical testing, they test it on animals, they test it on tissues and things like that, and say, okay, we think we have a drug that's going to be really good for people. We think it's going to be efficacious and safe. They go to the FDA and they say, hey, we would like to test with this. They'll look at the data and say, okay, you have an investigational new drug application. Here you go. From that point on, they have 20 years to bring that drug to market, make some money off of it before it goes off patent. When it goes off patent, anyone know what happens? Generics come out, right? So then anyone can make a generic drug and they can make some of their money. So again, they're incentivized in that 20-year period to do what they can to get through. So during that time, they're going to have 3 phases of trials. Basically, in phase 1, it's going to be in a relatively small number of people, say 10 to 100, healthy volunteers. They don't have the disease state in question. So if it's the new antihypertensive, these are people without hypertension, and they test it to determine what kind of dose should we give, what are the kinetics of the drug, how does it act in these people. If it progresses from there, it goes to phase 2, where they now give it to maybe 50 to 500 people with the disease in question to determine how efficacious it is. If that's still looking good, then they'll go to phase 3, and they'll do it on several thousand people. And at that point, they take the information back to the FDA and say, hey, we think this is good to go. FDA will look at it and they'll say yay or nay. If it's yay, then it goes out in the market as a new brand name drug. Okay. So you see here essentially how many chemical entities the companies are starting out with and the R&D going through to come up with a viable molecule. You can see here that really very few of the things they're actually testing make it to market, right? They actually make it to the post-marketing sort of phase here. Okay. And again, this gets very, very expensive. This can cost millions and billions of dollars to bring drugs to market because there's so many failures you have in the making of it. And this is why drugs can be so expensive. There's lots of other reasons it's complicated, and I'm not going to get into it, but it's very expensive to bring these drugs to market, and very frequently they try to recoup their costs for their failures by charging more for the drugs that actually do make it out to market here, right? Again, once they go through this period here, they have that 20 years to get through. Now they have their new drug application once they actually make it through. Now they're in what we call the marketing phase, or phase 4. So if any of you, and you don't have to say what drug, but have you ever taken a medication at any point in your life ever? You were a willing participant in a phase 4 trial. You didn't know that, did you? That's true. Because imagine we are only using these drugs in, say, maybe a couple thousand people. But what happens if there's a side effect that only happens in 1 in a million? Are you going to find it in that phase 3 trial? Highly unlikely, right? So that's why we wait until the phase 4. We're starting to give it to millions of people before we actually notice that some of these side effects may develop here. And that's why drugs can be taken off the market, is once they realize, hey, wow, this drug's actually killing people. We didn't know about it until we gave it to millions, but it's too high of a risk, and now we're going to take it off the market. Have you ever heard of a drug called Vioxx? That was a kind of a famous one, as even before my time, but it was a drug that was kind of touted as like, this is the NSAID to end all NSAIDs. This is great. It doesn't cause any GI toxicity. It's fantastic. Until they realized it was killing people, giving them heart attacks, strokes. So they took it off the market, and that's why for a long time, you know, those commercials like you see with the lawyers, like, have you ever taken this drug, or you or your loved one? We can get you lots of money for it. They were doing that same thing for Vioxx for years because of the fact that people were taking it, not realizing there was this risk, and then they had to pull it off the market.
When it comes to like all this controversy with like how expensive that depends on why are we dealing with that? I feel like I'm belong to this.
Yeah, so part of the problem is there like a generic available for some of those things? I mean, like some of it has to do with, I'll give you an example, like the albuterol inhalers. Back in the day, you guys remember like CFC propellants, so like in refrigerators and stuff like that, they're worried about the ozone being depleted because of the CFCs. And they're trying to get CFCs out of everything. Well, all the albuterol inhalers actually contain that propellant, right? Now, again, I don't know how many asthmatics were destroying the ozone layer, but they said, well, let's take all these CFCs out of it and replace it with HFA. HFA is a new propellant, so if you see like Ventolin or ProAir HFA, that's what the propellant is. Well, when they replace that, it's still the same drug, but guess what? Now they have a brand new patent on it, and now all these new albuterol inhalers are brand name only. Now they cost more. So it goes to show you that like some of these things, I can't say I know the hearts of these drug company people, but some of it may be financially related, right? So there's some of the issues with that. Some of it may be a supply and demand sort of thing there where they're difficult to make. EpiPens, it's an actual device, right? It's not just the drug itself you have to consider there as well. So it's it gets complicated very quickly when you consider all of that. So it's complicated. I wish there was an obvious answer too, but unfortunately there oftentimes is not. I'll give you another good example too. There's, for instance, out west, we have to worry more about things like scorpion stings, right? They're much more clinically relevant over there, like New Mexico and Nevada, than they are over here. And they were doing a clinical trial for several years for a new antivenom for these scorpions. And so if you're in a clinical trial, you don't pay for the drug. Everything gets provided for you, right? Because the drug company is actually footing the bill to test to see if they can put it on the market. And then as soon as it got approved, there are all these news stories coming about all these people getting stung by scorpions. Now they have to pay thousands of dollars for this drug. And they're like, well, yeah, because now it's an actual FDA-approved product. Like, someone's got to pay for it, and now it's you. You're the patient. But they didn't realize that they were actually just in the study, and that's why they were able to get it for free. So again, there could be multitude of causes there. Most of it probably goes back to the drug companies are probably evil and want to make too much money, right? So that's probably what it goes back to. Who can say? Anywho, here's another table kind of showing you essentially what this looks like in terms of how many people are involved, how many, what type of studies are being done here. Again, this is where we do things like randomized controlled trials, placebo-controlled trials. Why do we do placebo-controlled trials? Anyone know? Placebo effect, right? We have to show that even if I give you a sugar pill and I say, here, this is going to help with your blood pressure, mind over matter is a thing, right? You can actually see reductions in blood pressure. If I say this is going to help your anxiety right before right before your test time, mm-hmm. I give you this little tablet at 8:25. Say, here, you're going to do way better on your test. You may feel like, wow, Dr. Wood gave me this pill, and all of a sudden I feel so much more calm and at ease, and I'm just like, it's a sugar pill, but you did 10 points better on your test. That's that placebo effect, right? And we have to kind of isolate out for those sorts of things to show that the drugs we have are actually making a difference, right? They're actually having their beneficial effects there. But that's another topic we'll talk about later on there. Anyway, but again, human testing is only going to be once that NDA is actually, or the IND is approved for that thing there. And then phase 4 trial, again, no fixed time on that. Everyone who takes a drug, you're basically a participant in those trials there. And the average cost might have changed in the past couple of years here, but about $2.6 billion to bring it to market. Very, very expensive to do so, right? Again, another topic to get into is when you have something going off of patent, which means you want to produce generic equivalents of it, you have to prove something called bioequivalence. And basically this means that you, as a generic manufacturer, have to prove that your drug is going to have very similar characteristics to the brand name product, right? If you can prove that they're very similar, then the FDA will say, okay, well, you're allowed to produce this to sell as a generic. So you may have some patients who say, I only want the brand name, the generic just doesn't work for me. Very frequently, that is not true, right? Again, some of that may be the placebo effect. Some of it may be because the blue OxyContin sell for more than the other ones. Could be a lot of reasons. But in general, the generic should work just as well as the brand name drugs, okay? So if you ever see someone who has an issue with that, oftentimes, they say, oh, I'm allergic to the generic. It could be something to do with the tablet itself, maybe a binder or a dye or something like that. But in general, they should work very, very similar to one another. Here's an example of ibupropion. Anyone ever heard of that drug, what it does? Or for depression or like smoking cessation. So if you ever see that, that's what that's used for. But here's an example where there's an XL formulation. They had to show that it had very similar characteristics, and if it's within certain parameters, the FDA will say, yeah, go ahead and sell this drug as a generic. You're good to go. Okay, so that's called bioequivalence when you show that and you have a generic form out there. Okay. Any questions so far? How much time do I have? I have a whole 7 minutes. I'm going to see what I can get through. I can. So let's talk about receptor signaling, right? So what kind of receptors are we going to be dealing with here? And again, I mentioned receptors are any kind of component which drugs or an endogenous ligand is going to be interacting with, causing some sort of functional change within the body, right? And again, communication between different cells can vary depending on location of the different types of tissues that are communicating, how far the distance is, etc. And so you'll find that signaling molecules can be sent similar, very different ways depending on how it needs to be transmitted. And you've covered probably a lot of these in terms of physio, talking about some of these, but I'll kind of reiterate here quickly. But again, a receptor is going to be any specific protein that can be affected by a drug or some sort of signaling molecule. The effector is going to be anything that is actually binding to that receptor, whether it be insulin or epinephrine or anything. And then we'll talk about secondary messengers next time, but those are basically going to be the downstream things that actually cause whatever physiologic effect you're looking for, whether it be lowering blood pressure, releasing insulin, or whatever the case may be. Okay. So first off, you have contact-dependent cell signaling, where actually they're touching together. They can send chemicals amongst one another. This is very common or very important for things like cancer, where oftentimes once cells kind of get too crowded in together, they kind of tell each other, hey, stop growing, stop causing mitosis to occur. However, with cancer, guess what? You lose that, and then they kind of grow rampant. That's a form of cell signaling that may be somewhat aberrant. Okay, so it'd be contact-type dependent. You get a paracrine signaling, where basically cells kind of in a distant area, not too far away, but you're able to send out chemicals and can affect cells kind of in the same neighborhood of the tissue you're dealing with. So that's one way that can occur. And then very commonly, and we'll see this being used for a whole host of different drugs, is ways we can affect synaptic signaling. Have you covered neuro stuff with Professor Kaplan yet? Fantastic. This is a big, important way that a lot of drugs are going to be working here. So normally you're going to find that different neurotransmitters will be released onto these cells here. We can affect them in a lot of different ways. So as an example, we can affect things like serotonin reuptake by preventing serotonin from being taken back into the neuron. I have more of it out here, and thus that can help with depression, or it can help with anxiety, right? So we'll talk all kinds about drugs that affect neuronal synaptic transmission a little bit later on. And then another important one's called endocrine signaling. Most of our drugs sort of act like endocrine signalers because, again, you're putting it into the bloodstream and it kind of transmits out and can affect tissues all over the body. But again, endocrine cells can be anything releasing a substance into the bloodstream affecting tissues all throughout the body. So, for instance, T4, thyroxine affecting all sorts of tissues throughout the body, insulin, etc. Right? So, just to give you an example of different types of things that can be receptors, that can act as receptors. Sometimes enzymes can be receptors, right? So, as an example, you can have things that can either inhibit or activate enzymes to cause various types of effects. So, as an example, here's an enzyme called dihydrofolate reductase. And has anyone ever heard of methotrexate before? It's used for rheumatoid arthritis, used for cancer, used for lots of different things. Essentially what it does is it actually inhibits this enzyme called dihydrofolate reductase. This actually prevents your cells from using folic acid. By preventing use of folic acid, anyone know what that does? Can't make. Yeah, so you may see some anemias that can develop from that, but more importantly, you can actually prevent DNA production in certain cells. So by preventing DNA production, you can cause your immune cells to start to decrease in number. It's an immunosuppressant, so that can help with things like rheumatoid arthritis or other autoimmune conditions. It can help with cancerous cells and preventing them from replicating. But by interacting with this specific enzyme here, your cells can't use folic acid, and thus they can't produce DNA, and so you can start to see the downstream effects of that. So that enzyme is technically the receptor. Transport proteins can be affected by drugs as well, so these can be considered receptors here. So you guys have heard, I'm sure, of the sodium-potassium ATPase pump, right? Very important in physiology, right? Your heart, all your neurons, anything that can produce an action potential is subject to the sodium-potassium pump. Well, you can see here as an example where if I use a drug called digoxin, which is kind of an old-school antiarrhythmic drug, I can actually inhibit the sodium-potassium pump, and by doing that, I'm affecting the amount of sodium in the cell, which thereby affects the amount of calcium in the cell. And calcium is really important in the myocardium for doing what? Contractility. So if I have more calcium in the cell, what do you think that does to contractility? Goes up, right? So it's always good for CHF patients. That's why I used to use it for CHF patients, because it caused better contraction of that left ventricle, which is oversized and not working so well. So you can see how this transport protein can be affected by this, right, by medication. How about structural proteins? Anyone familiar with gout? What is gout? You have uric acid is precipitating out. What's kind of the one body part that normally gets affected you think about? The great toe. I don't know what's so great about it. I'd say my pinky toe is pretty cool, but great toe, okay. Anyway, the big toe gets usually affected. That's kind of the thing you think about. But by giving the drug colchicine, you can actually inhibit some of the microtubule formation and it causes a lot of those immune cells to come and cause that inflammation when you have that uric acid precipitating out. So by disrupting the mitotic spindles, you prevent replication of cells, you prevent chemotaxis, you prevent inflammation, okay? So again, this is where a structural protein can be a site of action for drugs here. Again, don't memorize these specific examples. I'm just trying to give you an idea of the different types of targets your drugs could be shooting for. So I will probably stop it here. We're going to continue on next time talking about the different main types of drug receptors. So we'll cover that. Let me check the board to see if there's any questions. I hope so. I get really excited when I get post-it notes on it, and not a single one. No one has any questions whatsoever.
I think you have to download the app.
No, you can do it from the web browser. So if you click on it from Canvas, so again, it'll come up and it'll say like, oh, this isn't a secure site. Just click on this and you can get to it. If any issues, let me know, because I like to encourage.
I saw one, but it was deleted.
It was deleted? Oh no. What happened to the phantom question? I'll never know. But is there any questions I can answer? Okay. Yes, ma'am.
I had a question about the rectal one.
Okay.
For the actual medication inside it, is it like a prevention or something? How is it then distributed?
Yeah, so basically you would find with a suppository, the drug is basically mixed into a solution. So basically the cocoa butter base would be in a liquid formulation essentially. You basically would have it at a higher temperature. And then you would mix the drug into it. So you get this nice homogeneous sort of suspension. Then you would cast it. So you actually have like suppository cast. And you cool it down, which makes it solid. You wrap it up in the foil. And then when the patient gets it, again, you have to be careful not to overheat it. So imagine if you left like a bunch of suppositories on your dashboard in the middle of the seat. Not going to be good, right? Yes, it's uniformly suspended. So as the cocoa butter melts, it'll then just basically be liquid and it just gets absorbed through the rectum there. Any other questions? If not, I will see you guys next time.